Well, welcome back, everyone. Hopefully you had a nice time either getting some coffee, some tea, and also hopefully you were able to visit our virtual booth and take a look at some of the materials we have there. So what we want to do now is take a little bit of a turn and think about kind of data's role in public health. I think public health has been especially top of mind over this last year and a half, going on 2 years now. And so we've assembled a panel of experts to share their expertise. Leading that panel is Crystal Sun, who is our Director of Healthcare Analytics. And before we get started, just a reminder, if you have a question, please place that in the chat. We want to make sure that our experts are able to answer those questions and get you all of the information that you need. And so with that, I'll turn it over to Crystal.
Thanks, Patrice, and thank you to everybody who's joining us today. My name is Crystal Sun, and I'm the Director of Healthcare Analytics at Civis. And I'm a former epidemiologist for the city of New York. So I'm particularly excited that we're devoting one of our Data for Gov sessions to a discussion about public health data. So before we start, I just want to say that because of the last 2 years, the field of public health has almost become synonymous with COVID. But it's really important for all of us to remember that public health is a really wide field of study, and it predates the pandemic by many, many decades. So we're really glad to have 3 panelists with us here today that are from very different areas of specialization within public health, including COVID. So without further ado, I want to introduce you to our 3 panelists, who are Alex Hans, Lungi Okoko, and Jason Metsa. I think I'll turn it over to each of them to give a brief introduction to themselves and how they've come to work with Civis in the past. So let's start with Lungi. Lungi, could you start?
Yes, and hi everyone. My name is Lungi Okoko, and in terms of a bio, I've spent most of my 15-year career at the intersection of data, technology, and infectious diseases and health system strengthening. So I've done work in HIV prevention, nutrition, Ebola, and now malaria. And so like many more developed nations, most African countries have had so many pilot implementations of digital tools and are generating large amounts of siloed data sets. And so I work with national and local health authorities, what are called ministries of health outside the US, and various other partners to implement strategies to scale those digital health tools and to establish interoperability between systems, and also to improve the way that data is used to inform key public health decisions. So currently I serve as the data integration team lead for the US Agency for International Development's presidential malaria initiative. We call it PMI. So that's the flagship U.S. government initiative to combat malaria. So we've been working with Civis Analytics for the past 2.5 years to develop a data science platform that we call MDive for the Malaria Data Integration and Visualization Platform. And that platform combines various previously siloed data sets, from disease surveillance data to supply chain data to financial and climate data, and also geospatial data from the 27 countries that we partner with. So with Civis, we've been conducting user research with government officials and public health managers from our 27 partner countries in Africa and in Asia. And we run 2-week sprints to incrementally build out MDive over time with new data sources, new API connections, new features, and new functionalities. So pleasure to be here, and looking forward to this panel.
Thanks, Lungi. Glad to have you with us. Jason, could you go next?
Yeah, Jason Metsa. I'm here with the state of Minnesota. I'm a recovering politician of a few years and started this work actually. I work for a smaller state agency up in the mining area of northern Minnesota, and we do economic development in the kind of life in state government. During the pandemic, they needed help at the Department of Health, so I volunteered to go over a little over a year ago, and ended up helping run our testing sites around Minnesota as they got up and operational about 6 months into them coming on board, and then worked with a small team to get our vaccination pilot sites up and running, and then was fortunate enough to have the connections close enough to the governor's office to pitch a crazy idea of basically doing outreach in advance, because we knew that there was a huge onslaught of demand at the beginning, but we could see that that was going to leave a large vacuum. And so we started that work last March, and we utilized the Civis database to basically take all of our different communication tools, set up APIs so we could have self-reporting of all those different tools and eliminate some of the time that it would take to disseminate the information afterwards. And then built it out also for security reasons. Healthcare data is very, very, very sensitive. And we knew going into this that our data security was going to be how we made or broke our program with the legislature. And Civis has helped us achieve, being up and standing much longer than we were originally planning on being around. So I'm looking forward to being here as well.
Great. Thanks, Jason. And last but definitely not least, Alex.
Hi there. I'm Alex Hans. I've spent the last 7+ years in government and political communications in the state of Illinois. The last 4.5 has been with then candidate and now Governor J.B. Pritzker. In the pandemic, my role shifted from just one of the many communications folks that are, communicating the agenda to almost 100% COVID-19 response. I've been partnering with Civis over the past 18, 19, 20 months, however long this has been, to run message tests, surveys, use their Vaccine Outreach Intelligence Center to help plan campaigns around mask wearing, safety practices, and, the behavior change that, is important for implementing, safety practices and most and certainly not least vaccine hesitancy and confidence. Excited to share all of that with you today.
Great. Thanks, Alex. And thanks for being with us. It's been 20 months, I think, but feels like 20 years a lot of days. But I thought we could kick off with asking each of the panelists, what are some of the critical decisions that you and your organizations that you work for have had to make and are making? And how has using data been really instrumental in making those types of decisions? Maybe we could start with, let's go in the reverse order. Alex?
Yeah, so in my world, we're planning the strategy, the creative, and how we're targeting a variety of media campaigns. And these are because of the generous aid of the federal government, media campaigns that are tens of millions of dollars. And, we want to make sure that whatever we're doing is, reaching the right people and doing so effectively over time. We've used the variety of tools at our disposal with Civis to really understand who is our target audience, zero in on what are the attitudes, behaviors, and beliefs that these folks have, and how do we, craft a message that works. And with all these variety of tools, we've been able to really hone in and know what is effective, what isn't effective, and put our dollars and spend them wisely, even though it may sound like a lot of money. I mean, we're in, the Chicago DMA is very expensive for television. And we want to make sure that we're reaching the right people with the right message. So that's how, data is involved in our strategic decision-making around the marketing campaigns.
Yeah, and Alex, you're a prime example of someone whose work before the pandemic hit was not COVID related or not even public health related, right? Can you talk a little bit about how you were pulled in the early days of the pandemic unfolding in Illinois into this type of work?
Yeah, in the early days, the first month, I was helping craft the press releases, which was something more common of my role in addition to our social media. But as things got, worse and worse, I think we realized, and this was really a top-down decision and a great one by the leaders in our office that said, we need a platform to rally our residents together, and to, we're experiencing these unprecedented circumstances, and we need to communicate them not only from the podium and from, the governor giving his daily press briefings with the director of public health, but, we need to use paid media. We need to use every tool to reach people where they are. And more often than not, it's spending hours and hours online, So, we launched an initiative called All in Illinois as really this banner to help drive people to the right actions. And it started with, wearing a mask, in the middle of the first COVID summer. As we shifted towards the holidays, we knew that it was going to look very different. We had a variety of things that we needed to communicate, and the data that we got and the understanding that we got of where people's heads were at helped us craft that overarching strategy. And with vaccines, we're now in month 10 or 11 in the vaccination campaign, having started in December of last year. And we have launched 3 vaccine campaigns so far on paid media, and are planning another 2, which is a meeting I'm running to in a little bit, armed with some really great insights that will make sure that we are always reaching the group that we call the movable middle, which is the folks that are obviously not first in the line to the vaccine, and also not the folks that are never going to get it, but the people that are truly considering is this right for me and my family? So we've been really fortunate to get great insights that help us identify and speak to those people specifically.
Yeah, that's great. Jason, if I could ask you the same set of questions, one being, what are some of the examples of key decisions that you have to make using data, and you've been able to see where data is an instrumental part of that? And then 2, if you could talk a little bit about your personal experience in the early days of the pandemic, that would be great.
I suppose I got to come off mute for that, don't I? The early part of the pandemic was really eye-opening for me. You had seen it all on TV. Like I had said in my intro, I came in a little bit late in October of last year to the response in Minnesota. And kind of what we realized right away was that every single person was being overworked and not given enough resources, and not because of lack of resource necessarily, just because we couldn't get the time off or transfer people over through other state agencies to relieve the workload soon enough. So going through the logistics of that and watching really inspired me to feel like I was part of something really good, and made my family decision to put in those long hours like everyone else has in this field for the last 2 years a lot easier. And so some of the challenges we really faced early on in setting up our program in Minnesota, we had what data were we going to use to reach out to people once we got to a point where the low-hanging fruit in terms of folks who were less hesitant had gone through our vaccination clinics. And then how were we going to reach out on top of our paid media? And we decided to launch a phoning program, a texting program, and an email program. And so we had to go out and buy a commercially sourced data set because of the individual state laws here in Minnesota, and then find someone like Civis to house that data and manipulate it so that we could actually make more effective decisions. And so I think that was one of our biggest challenges, was just getting from a point where most states have immunization data team. Ours is called MIC here in Minnesota, and getting that data shared with our program on a data lake so that we weren't getting the things we weren't supposed to was very challenging. And then getting that data to match, one thing I've learned is if programmers aren't writing in the same language or using the same programs, some of that arbitrage and loss in those files can amount to hundreds of thousands of phone calls, in our case, getting made to people who didn't necessarily need them. Not that we don't want to be reaching out to everyone, but we knew that a certain segment of the population was going to be responding to media, to text, to an email. And most importantly, say our seniors who were living at home, who might not have access to those with a lack of family around to help, whatever the case may be, and or anyone in that similar position if they aren't a senior, right down to folks like we talked about earlier, getting an equitable portion of our program so that we could focus on parts of the community that really needed that extra information to make the right decision for them and their family. And so our program getting up and running enabled the other teams already in place to kind of double down on their efforts. And then we really focused on just helping augment all those efforts and have found kind of our niche there.
Yeah, that's a really important point, to focus on the not only your broad reach and reaching the people that you want to, but also not reaching the people that you don't want to, in order to make your efforts more efficient and effective over time.
And I guess I would just add one thing we're doing with that is I mentioned the MIC. We're taking out everyone who is been vaccinated and reported to the state, and removing them from our list so we can keep narrowing in the program. So
yeah, that's great. And Lungi, if we could switch to you too, what are some of the types of decisions that you are tasked with making using data? And then if you could walk us through what the early days of the pandemic were like for you, that'd be wonderful.
Thanks, Crystal. So yes, similar to my colleagues, a lot of the decisions that we make have to do with how resources are allocated from a government agency perspective. So for us, malaria is the number one cause of outpatient visits at health clinics and facilities throughout Africa. And then it also kills nearly 500,000 people in Africa every year, which is way more than the COVID-19 deaths that the continent is projected to experience. And so we're trying to understand the impact of the pandemic on the delivery of malaria services. And as part of that, also working with African countries to control and eliminate malaria by improving the way that we target our interventions and target the allocation of financial, human, and technical resources, since those resources tend to be fairly scarce. Our overall budget is about $700 million a year, but we're start serving more than 24 countries and populations that go well beyond the 700 million threshold. And so we want to make sure that those scarce resources go and are available to the right places and the right time and at the right level of quality. So one of the things that we did, a good example of that is our work in Ethiopia, where we work with the Ethiopian government to integrate their climate data with their disease surveillance data to develop an early warning system to identify 2 to 3 months in advance those specific, what's called in Ethiopia, woredas or districts that are most likely to see upsurges in malaria cases. So in that case, the model was developed and used machine learning to forecast those cases. And we're able to provide the forecast with 70% accuracy. So 3 months ahead of time forecast with 70% accuracy. And that's a game changer for us, because in the past, whether it's with malaria or with Ebola, my frustration, and I think frustration from many of my colleagues, has often been that it feels like we're chasing the disease and don't necessarily know where the next part of the country will flare up. And so those forecasts then help us and help the government to send those medical supplies, the rapid diagnostic test kits, the antimalarial drugs to those specific locations that are most likely to see outbreaks. And then we're learning from that work, we're working towards prototyping a global version of the Ethiopia model that could serve as a global early warning system, so that we can integrate the disease surveillance that we have across the 27 countries that we support with the climate data that comes into our platform from Google Earth Engine to then provide those forecasts, and so that as many districts can benefit as possible. So early days of the pandemic for me, it's interesting. I was actually in Nigeria with colleagues from the Civis team and also some of our data scientists, and we were doing a user research with the Nigerian government with their national malaria control program to to understand their needs and based on the data that they have, and that we could also merge with data that we had at the global level to help them make better decisions, again, on resource allocation, and also to negotiate a live connection to their disease surveillance database. And so end of February, jump on a plane, I'm on my way back to home, to the DC area. And that's where I see on television that they've had their first case in Nigeria that was confirmed. And what that led to was, as you saw across many other countries and around the world, just a massive shutdown with travel restrictions. But the effect that it had on the delivery of malaria services is that a lot of the messaging that was happening, even at the top levels of governments early on, was around not going to the health facility if you have a high fever, which goes against the messaging that we had been promoting and pushing with the governments over the past decade or so. For us, it's important that fevers are diagnosed to figure out, to rule out whether it's malaria or not, and then treat it if it's a malaria case. And so those contradictions became harmful. And as we were developing tools to track the impact of COVID on the delivery of malaria services, we started to see a reduction in attendance at health facilities that caused some worries on our side. So that provided some information that helped us with governments and other donors work together to push behavior change communication campaigns to revert back to really encouraging populations to go to the health facility and to clinics if they're experiencing very high fevers. So that was the early days, but throughout, I think we've experienced some challenges around the supply chain, and that's also affected the availability of malaria, antimalarial drugs, and rapid test kits. And so our supply chain team has done a good amount of work with the data that we have to help address those issues and to reduce stockouts.
Thank you. And are some of those issues resolved, or is a lot of that still in effect today? Have things gotten better?
It's an ongoing issue. I think that our supply chain team has done some phenomenal work with the data that they have and the resources that they have. But it's it's way bigger than just malaria commodities. So the impact on the supply chains. So it's very much an ongoing challenge.
Mm-hmm. Yeah, and you use that phrase, the data that we have, and I think that alludes to the common problem that all of us who work with data always have, which is data is never perfect. It's never complete. There are always holes. There are things that you can't join together the way that you want to. So if each of you could talk a little bit about that and the tension between, we have an urgent decision or set of decisions that we have to make, and it's going to have to be based off of imperfect data, versus, no, we need to make the investment and build the pipelines. This is a long-term runway kind of initiative. How do you sort through what the benefits and the cons would be of that type of decision making? Let's start with Jason.
So I think we faced this almost periodically throughout this pandemic in a multitude of different ways. I think of when we started to discuss, as I was starting this program, I was still managing our testing program, and we weren't getting the use that was really needed to keep them up and running. So we had to project out and kind of see, like, if these trends continue, will we have the usership to, justify having, National Guard teams deployed, thousands of nurses around the state on payroll, companies standing by to do all this work. And it really helped when we started to disseminate the trends and to put us in a position where we were able to better defend the decision to the public. because everything is so quick changing in this in response, and a lot of administrations are just trying to go with the science, and we're learning every day that I remember when masks first came out, for example. That was a huge issue here in Minnesota because we had gone out and said to the public, like, you don't need masks, and then like 2-3 weeks later we're going back and saying. So whether it's that, whether it's testing, getting ahead out on those trends and being able to disseminate, and just being, even if it's a half step ahead in something like this, puts you in a position where you can be maybe a step ahead for that next decision that's important. And so I think it all kind of melds together, and just being able to assess everything as it is, with the data being imperfect, and draw the best conclusion you can and move on. At least having that subset to draw from to be able to make that decision brings a lot of comfort to a lot of people who have a lot vested in this response that we've all been a part of. So,
yeah, that's great. Alex, what about you? What are your thoughts on this?
Yeah, at the, in our first campaign, when we were really focusing on mask wearing, we were looking at the case data that, we knew was pretty reliable. In addition to, data on mobility and just how much people were moving around in different counties. That was about as, back then it was sophisticated for what we were doing. And, when we knew that, the vaccine rollout was coming, and that it was so politically charged, that so many people had so many different thoughts, we knew we really needed to build out a, research system that was going to support that ever-changing target. Wearing a mask was simple compared to getting, people vaccinated. So we designed a series of, monthly surveys where we're tracking attitudes and behaviors over time from, the early days through now, and is going to be ongoing, to really understand, what is the composition of the unvaccinated population? What do they believe? What's changing? What's staying the same? And to layer on top of that, we, at the beginning, Civis has done just a recent national message test that shows just how much, the communications and what you're saying changes from, back when we started this to now. And the final piece, I think, as we're moving from kind of a really broad effort to a much more local effort, we're using an additional tool that really zeroes in on the zip codes, where you have, inputting census data, vaccination data, and a model on vaccine hesitancy to really understand what groups of populations are where in any geography. And we're using that to launch probably half a dozen different tracks of messaging in our upcoming campaign. So it's gotten a lot more sophisticated over time, as we've realized that, we're dealing with a much more complex issue.
Yeah, I remember that, the very beginning, there was data on people who were hospitalized, and then there was data on people who were testing positive, but there was no data on how do people think, how do people feel, what are the obstacles to them to putting on a mask. And so that's one of the things that we embarked upon, and hopefully to fill in the missing piece of the puzzle there. Lungi, what about yourself? What were, how would you respond? How would you think about the tension between those two things?
Yeah. So for us, improving the accuracy and quality of the data that we have and that the governments that we support collect is extremely important, because it really can be the difference between life and death. We have situations where malaria cases are overreported, and malaria commodities, so antimalarial drugs, are overused, and which creates then stockouts in the near and longer term future for those individuals that actually need those antimalarial drugs, and so. Extremely important. At the same time, the goal of near perfect data quality, or even perfection as the enemy of the good can be a major barrier to data use. So there's that, as you mentioned, that real tension between, the need for high quality data, but also the need to use the data that we currently have. And I've encountered, at least two schools of thoughts, and many of my colleagues will be somewhere within that continuum of, emphasizing garbage in, garbage out, and refusing to use data until it has reached, near perfection. And then others that are more willing to use messy data with known data quality issues, but still willing to use it. And so a lot of it requires cultural change within the organization, and getting to a point where we are comfortable with seeing the data that we have and visualizing it, but with annotations, specifying the data quality issues that we know, and also the contextual factors that may have played a role in what's happening, as well as in the data quality. And then creating that feedback loop where, as we're reviewing and together the data that we have, and looking at trends, then making inputs and identifying data quality issues so that they can be solved, and so that the next data update can be of higher quality. It's been great working with our CDC colleagues on this, and the Civis team on developing automated data quality validation and quality control workflows, so that those improvements can be made, and data quality issues can be flagged. But it is very much a tension that we feel and experience day to day in our work.
Yeah, and I think what I'm hearing from you in that is like there's almost just an assumption going in that your data is never going to be 100% perfect. And it's just the question of the day is it perfect enough for me to feel confident making this decision off of this imperfect data? Another tension I thought we could talk about is, because there are a lot of tensions in public health, this struggle between, that are serving government clients, those of us that work in the public sector, we are obligated to serve the entire community and have the health of the entire community as our priority. But at the same time, we also want to empower people to own their own health and make their own decisions. And so how do you think about, that balance between, like, health is personal to you, you as an individual make your own decisions, and the other side of the coin, which is we need to build the built environment around people, empower them with the information that they need in order to lead a healthy life. Lungi, do you mind kicking off?
Yeah, that's a hard one. I think where in the countries where we work, we're very much in the early stages of tackling this issue. For me, at the core, a lot of it has to do with ensuring that the patients that we serve in the population that we serve are able to provide adequate informed consent. And in the medium to longer term, also end up having access to the data about themselves as well as about the community that they live in. But we haven't made as much progress as is needed. I think what the future would look like is very much, we have a few examples like in Uganda where scorecards have been developed for villages and for districts. So at least the population knows what data is collected about them within the disease surveillance systems, and they're able to visualize how their community is faring compared to others around them, to sort of in a way keep the government accountable for the delivery of services to populations. But there's a lot of room to grow in that area in global health.
do you see any really marked differences with your global perspective versus what you see in the U.S. when it comes to that?
See, it's hard for me to answer questions about what's happening in the U.S. because all of my energy and focus is overseas. But just from my individual perspective, just the fact that I have access to my medical records, within the network of service providers that I visit, and I'm even now able to exchange and share my records with another network of providers is it seems like tremendous progress. So I think that's a good example of where we should be headed in Africa and Asia as well.
Mm-hmm. And Alex, could you jump in on that question of how do you balance like serving the individual versus, we are in public service. We are here to offer the whole community and serve them.
Yeah, I think it really, when you're looking at an issue, and obviously my experience is limited to kind of this marketing these issues and trying to get people to comply with public health measures. I think you probably, we started big and you just narrow as you go and focus on the people who are actually, probably not following. And I think by keeping the focus on that group is a public benefit. So I don't think, a targeted strategy means it's something that is not serving everyone. I mean, certainly it's not serving everyone equally, but some people don't need as much work to convince to do the right thing as someone else.
Yeah, it's sort of like a good compromise between where, the older school, like blanket strategies, we're going to reach out to everybody just, based off of their demographic profile, and an individual outreach strategy, which is just not scalable and not cost efficient, probably. Jason, what about yourself? What are your thoughts on that?
Well, I know I was listening to Dan and DJ in the presentation before this, and I thought DJ nailed it at the end when he had stated that, everyone working in data should take an ethics class. And, I really think that rings true for me. We've got a lot of teams, and I really respect the work that they've done and put into this. But we are faced with impossible tasks. I remember when we were setting up Minnesota's first, for our 65 plus, once that became the popular group to vaccinate first, even though it might not have been the best one for public health, how do we ethically go through and make sure that people are getting fair access to the same thing at the same time? And we learned a lot of tough lessons. People, white people in particular, that lived in our suburbs and metropolitan areas would drive 6 or 7 hours to go get a vaccine in a site that was, really geared towards indigenous or rural communities with different issues, whether they be financial, political, or whatever. And so I think the hard part for a lot of folks is like really having that conversation, because there was a point in time where it wasn't like the governors or the president or anyone, playing God on the ground. It was individuals out there working the front lines in public health who were trying to equitably distribute a life-saving vaccine to people who needed it most. And I just look back at that and think, how challenging. We made some poor choices along the way that we learned from, and then incorporated them once we went from our pilot phase in that launch to the general public. And I think we really, identified that we needed a team that was specifically looking at the equitable distribution. We needed a team that was looking at rural, at mobile clinics, at church clinics. And so we really took that approach, and, we're thankful that we had the support from our commissioner at the Department of Health in that.
Yeah, that's great. So we don't have much time left, but I want to make sure that we end on a positive note before we head into Q&A. I think it's been, pretty well documented so far, and we're hearing this from our partners in the public sector, that it's been a challenging time, and a lot of folks are, have been pushed to their max. And so if you were to give folks in public health, or even like who want to, are interested in joining public health through the public sector, what words of optimism and encouragement would you offer to each of them? Alex, let's start with you.
Yeah, I think if the past 20 months hasn't taught us, it's taught us quite a bit. And I think one of the key things is, we could solve any problem that comes our way. I think like people have been so creative, put themselves out there, and have done amazing work. I mean, here in Illinois, sorry, Jason, but we're the vaccination leader of the Midwest. You're right behind us, but we love to say it. So I have to give a plug to that. And, like, who would have thought that, now at this time we're looking at probably a smaller group than we would have ever thought of unvaccinated people. And we have to really dig in even deeper to understand some of these things. So I think when looking back, it's like there's really nothing that I think is impossible if we have, good people working together to get to a solution that really benefits us all.
Yeah, that's awesome. Lungi, what about yourself?
Well, for me, it's interesting. So as I was completing my master's in public health, I had people ask me like, what is that? Like, what does that mean? What will you do? And so I had to explain, because before I studied the doctorate in physical therapy. And so I have a focus on patients, at the individual level when I do clinical work. But then public health, you're looking at populations and sort of the impact of diseases and how to keep them healthy. But now with COVID, it seems like it's become almost a cool profession. And, so for example, you have, epidemiologists and modelers that are presenting at the White House, and my kids are watching that. And so to some extent, it sort of gave me cool points with my kids. So that's a major benefit. And then the other part is, haven't traveled since February 2020. So we used to essentially go to Africa once a month or once every 2 months. So that it's given me a lot more time with the family, which I'm grateful for. And we're learning, how much work can be done remotely with our counterparts within foreign governments. And I think we will still there's nothing that can replace in-person interaction, and especially the hallway conversations that happen for those types of negotiations. But just the ability to stay home for a few months has been extremely rewarding. Yeah,
I always tell people that, 2 years ago, people didn't know what an epidemiologist was. Mm-hmm. I would tell people that that's what I used to do, and I would get the question, oh, is that a dermatologist? Right. And now it's just part of the, household vocabulary, which is really cool to see. Jason, what about yourself? What words of positivity can you offer to people in public health today?
Yeah, so I would just say, like, I came at this, I've done some cool jobs and had some cool opportunities in my life, from defense contracting on building armor systems during the Afghanistan 2005, 2006, to being a state lawmaker. Fortunate, in my life, got appointed recently in this term for the governor to be a deputy commissioner. The best damn job I've ever had is working with y'all in public health, okay? It is so much fun, so mentally challenging, and to, have a team of people who you don't have to ask if they're dedicated. You can see it in their tired faces every morning, and feel part of a team that's doing such good things for the general well-being of just other human beings that you don't know, that you probably might dislike a bunch of them. You might love a bunch of them too, but like, you're doing this just to make the world a better place. And there's no better field that I've seen out there on my years, which are not that many, 40 so far, that is as rewarding as this one. And so I'd highly recommend to get involved in any way, shape, or form you can. This is, I think, the beginning of an endemic for this particular disease, and there's going to be a lot of work to come, and we need all the help we can get.
I don't think there could be better words of endorsement for the field of study, for working with folks in this discipline. So thank you all for joining us. Unfortunately, we've had a really great discussion and won't have time for Q&A, but for those that have placed questions in the queue, we're tracking all of those and we'll get you a response to those following the presentations. So thank you again.